I'm Kathryn Fraser, and I'm the psychologist and behavioral medicine coordinator in the Halifax Health Family Medicine Residency in Daytona Beach, Florida. And I'll let my co-presenter introduce himself. Go ahead, Hernan.
I am Hernan Barenboim. I am the behavioral science director at the All Saints Family Medicine Residence here with the Medical College of Wisconsin in Milwaukee, and assistant professor with the same college. Nice to see all of you.
All right. So welcome to our presentation. No struggle, no progress, keeping the anti-racism conversation ongoing. So I thought I'd start the talk by explaining the title to you. So the keeping the anti-racism conversation ongoing, that part comes from Hernan. And some of you might recall, we did an anti-racism plenary last year, and afterwards, Hernan was all fired up. We're both very passionate about this topic. He said, you know what, Kathryn, we have to keep this anti-racism conversation ongoing. And I said, yes. And you know what? That's a great title. So that part came from Hernan, and the part, the no struggle, no progress, I clipped that from a saying I found. And that really represents the tone of this work and how difficult it can be and challenging, but we really believe that it brings us together. You know, I really want to give kudos to the folks who presented this morning, Krithika and Carly, presenting on wellness and including issues of minoritized individuals and individuals who are doing DEI work, because that's such an important piece. And I really believe that when we're all healthy, then we all do better. So I want to welcome you into this space that we hope to create a sense of safety and really encourage you to come into this gathering with a sense of togetherness and being able to work on these situations and problems together. It's difficult work, it's deep work, and we really believe in it. And we just really encourage you to be as fully present as you can and to really engage in the experiences that we're going to present to you. So I do want to point out to you, a lot of what we are talking about today and presenting is in the anti-racism toolkit that is uploaded to the resource library. And we have the link to the toolkit in the chat box. So that can be a supplement to the things that we present today. Hernan and I also went ahead and put our email addresses in there in case we run out of time for questions at the end. So I encourage you to cut and paste that email and hang on to it in case you have any questions for us. So welcome to our talk. Next slide. We have no disclosures, and these are the objectives we hope to address today. We want to address this notion of privilege and have people self-reflect on their place of privilege, or perhaps not having privilege, and how it affects them as a healthcare provider, and to really think about how it affects our coworkers, our residents, and so on, and what they can learn from that. We want you to be able to start working on an anti-racism curriculum. And for some folks, you might be already on the way. For some folks, you might just be scratching the surface. But we really believe that everybody can take a few steps, hopefully, as we progress through this. And then also, we're going to show you not only some examples from the toolkit, we will take some examples from the toolkit, and we'll actually go through those activities. And hopefully, you'll be able to enact some of those once you leave. Next slide. So, so this slide is on the current climate on race, and I'm actually going to go off script a bit on this particular slide. And I just want to share with you a conversation that Hernan and I had in the last couple of days by email. Hernan sent me an email and he said, I'm still trying to process this, and he sent me a link to a video. And it was the video of the news reports of the Haitian migrants who are not only being turned back in droves from the Texas border, but they're also Border Patrol agents there on horses. They've seen them on horses with whips kind of going after the migrants. And, you know, this is what we're talking about as far as the current climate on race and conversations that are going on in our country right now, and national issues and world issues. And I think it's important to understand that, you know, for Hernan and I, it resonates with us for many reasons. We're both immigrants ourselves. and to really realize that your residents and your coworkers who are BIPOC or could be immigrant or whatever it is, whatever's going on, it really affects us. It affects our well-being and our functioning. And we really feel that a major theme for our talk is that we feel that behavioral faculty should really take lead roles in helping people to be able to process these conversations and to understand how they affect you as healthcare providers. So, and hopefully you'll download our presentation later on and actually read through this slide, but I just wanted to go off script and just share something with you. Next slide. So an important part of this conversation that not a lot of people know about, you know some of it, but not all of it, is America's history of race and racism and how that affects health. And we know that families of indigenous and enslaved people were torn apart and disrespected. And not only was their healthcare not addressed, but just their lives and their well-being. And so we have a deep history of people being oppressed and mistreated and not receiving healthcare for that. And we know that for many years, ethnic minority groups were denied equal healthcare. I recall, I've been here at Halifax since 1994, and I recall a few years after I'd been here that the place where our family health center was located, one of our administrators who had been here for a long time, a white gentleman, told me that that was the area of the hospital where the Black patients were seen. And it sort of shifted my perspective a bit to even think that here is somebody living and breathing who is telling me about this. So, you know, we have a long history of denying healthcare for people of color, and not only denying healthcare, but denying them the ability to even be able to become doctors and to go to medical school. And I don't know how many people know that that's part of the history of how the HBCU medical schools came to be, was that Black folks had to develop medical schools if they wanted to become physicians themselves. So America's history of racism and how it affects the health, particularly of BIPOC folks, is very deep and long. Next slide. So because of this, there is definitely a lagging behind of research and BIPOC healthcare providers, and there's just not enough focus on healthcare of BIPOC folks. We are very underrepresented in the field of medicine, and so there isn't a diversity of cultural health interests. The cultural health interest in our American healthcare system still favors the majority of the population, the white population. And so there's not enough research on the unique health needs of certain ethnic groups. And the COVID-19 pandemic certainly exacerbated this and didn't start it, but it makes us think about it more. And I'll share a little bit more with you about that. Next slide, Hernan. So COVID-19 has really exacerbated how it shows how disproportionately people of ethnic minority background have suffered from COVID-19 because of many of these factors mentioned here in our slide. So we know that, for instance, ability to social distance, you know, a lot of people of color live in housing, many people living together in the same place. It's difficult or impossible for them to be socially distant. And also we know that a lot of BIPOC folks work in those industries where they don't have the luxury of working at home, and they don't have the luxury of taking time off, you know, in the service industry. And therefore it's hard for them to do the things that they need to do to social distance, to not be exposed to COVID-19. And all kinds of access issues with healthcare, with the disparities of lack of economic access, transportation, education, all those kinds of things that also spilled over into how COVID-19 affected BIPOC populations. Next slide. So going back to what is our role as folks in behavioral medicine. So we really think that diversity and inclusion in the workforce would promote effective healthcare research and practice and effective, better treatment of people of minoritized backgrounds. So how do we do this? How do we get people to overcome the long history of racist attitudes, and we know there's overt racism and implicit bias, and it all needs to be worked on. And we feel that behavioral health specialists are uniquely qualified to conduct the kind of healing conversations that need to happen. So there's the diversity of the people. We want to move towards equity in policy, practice, and position, and then the inclusion of BIPOC folks in positions of power and positions of decision-making. And only when we get to that point will there be better equality in terms of healthcare and healthcare education. And so those are difficult conversations, and we really encourage our behavioral colleagues to get involved in this work. Next slide.
So yes, I think that the last point that Kathryn said is extremely important. And then there is no a different system of distribution of power. It's going to be really, really difficult to put a final or an end to this crisis that we have, that is, you know, systemic and has been here for decades, or actually centuries of years. So, you know, a big part of this is I think also because most of the people that is not part of a disadvantage or a minority group, they really don't know how is all the suffering that disadvantaged groups have, and this is because obviously the news don't show all what is really going on, not just in America, also around the world. Some of the consequences really about racism, you know, my first thought when I think about racism is, okay, something about mental health can happen. Someone that suffer any type of discrimination can suffer depression or probably any type of stress. But actually, after I did some literature review about this, I discovered that there are much more conditions, and several of them actually are not just psychological or medical. So in a systematic review that was done in 2015 of 293 studies, yes, 293 studies, that they studied all papers about racism consequences in health in general, including mental health and physical health. They, during 30 years, they found what I first said, that is, yes, there is racism has an effect in depression, in anxiety, and in stress from a mental health standpoint, but also in health. Basically, most of the people that at least have, you know, that at least says that they have one incident of feeling any type of racism against them, they are going to have worse, poor health outcomes in comparison to the status quo population in general. Something also interesting about this study is that there is no need to control for demographics, that this is always the first control variable that we think when we are doing research. You know, okay, tell me about age, gender, and SAS. And actually, none of these control variables made any change in the significant discoveries that they did for the health and mental health outcomes. So age or birthplace or, you know, sex actually don't impact, you know, in whatever regression you do in this type of research. Something interesting is that generally people from Asian countries, first or second generation, and Hispanics have a little more significant associations about mental health problems, and the color of the skin, the darker the color of the skin in general, besides whatever ethnicity we are talking about, generally includes more poor health outcomes. Why is that? We don't know it. But yes, there is, you know, the color of the skin is a very interesting control variable to see that the consequences in health and ethnicity for the consequences in mental health. So this is something that when I read it just took my mind, and I asked you, Kathryn, please, we have to include this thing. You know, it's like, as I said before, you know, age is not a significant variable in order to try to see these bad health outcomes in kids or in adults. We are seeing the same. But this statement from the American Academy of Pediatrics, I think that is just, you know, is very representative. That is, failure to address racism in the United States will continue to undermine health equity in all children, adolescents, emerging adults, and their families. So, you know, sometimes I think if we don't do it so much for ourselves, we have to do it for our children. But there is of course you know a systematic problem with this that can affect all the families. One thing just to add is, as I said before, there is we don't need to control for age to know all of these bad consequences in health, but just two more things is like, depending the darker of the skin, also people mothers have poor birth outcomes. Okay, generally the darker the color of the skin, the more problems of infant mortality and low birth weight. And as I said before, with adults, there are the same chronic conditions, the same PTSD, and the same depression.
Thanks, Hernan. So I did mention a few of these points at the beginning of the presentation, that it's difficult work and deep work. We come together, hopefully in the spirit of support. We respect that there are varying comfort levels. And, you know, we, as we're presenting this, we're also trying to model for you what it might be like for you when you go back to your programs and do some of these presentations. So you can prepare people. It's going to be difficult work, and we want you to really, as much as you can, be present and move through that discomfort, which we really believe will lead to growth. Next slide. So the first activity we're going to do is a privilege walk activity. And actually, we are not going to do this one by breakout. We're going to do this one all together as a group and have you send your responses into the chat room. So the way we're going to do this, you can see the activity has the word walk in it. So normally a way a privilege walk is done, you stand and you step forward or you step backward based on the statements. But what we're going to do today, we're just going to have you go ahead and read the statements and give yourself a point for each statement that applies to you. So it's 2 slides. So there are 12 statements in all. So Hernan will hold this slide for just a few seconds, and you can go through whichever one of yours, give yourself a point, whichever one applies to you.
Yeah, just one thing that I want to add to what Kathryn says is that in the activity that you're going to find in the Toolkit, okay, that we're going to share the link, or you can find it in the library as well, you are going to see that there are more items. We are showing just a little shorter version in benefit of time, okay? So
I think you can, yeah, you could go to the next slide.
Okay.
So that's the second set of statements. So go through and pick out the ones that apply to you. And then when you get to the end, put that number over 12, and we'll talk about that. Okay, you could go to the next slide, Hernan. So originally, we were going to go into small groups and talk about this, but actually what we're going to do instead is to have everyone give their responses in the chat. And between myself and Hernan and our illustrious assistants from MCW, we will be monitoring the chat. So I see that people are already putting their totals. That's great. And I'd like to ask the question, how did it feel to take part in this activity? If you feel comfortable, just send some words into the chat. Humbling, a good reminder.
The lower score that we have is a 6, and we go until a 12 in some cases.
Okay. I see someone mentioned some questions were surprising. Didn't know I was different. Found some discomfort. Great questions to think further about privilege. Humble, thought others would be more similar to me. Very good. You know, y'all, you are so lucky because there are no wrong answers in all the exercises we're doing. There are no wrong answers. You do not have to worry about a thing. So, and I'm being a little tongue in cheek, but we do appreciate your openness about this. Someone says, makes me think about my daughter and impact of how she is being raised. And yes, absolutely. So next question we'll ask, how did it feel to see your score and feel that sense of privilege, or to not have privilege. And you can, since we don't know, we won't all remember the scores, you can say privilege or not privileged, privileged or not privileged when you put your response in the chat. So what score would not be privileged? That is absolutely a great question. And what I would say, Kwanzaa, is focusing on how the activity made you feel. So maybe you look at your number and you feel, oh my gosh, I have privilege that I didn't think about. Or you might stop and say, most of these don't apply to me. I guess I don't have privilege, or I didn't come from privilege. Someone's privileged in ways I didn't recognize at that time in my life. Danielle mentions not privileged makes me humble and thankful to those along the way that helped and supported me. Absolutely, I can relate to that. Realizing that I had privilege was revealing and began an introspective journey. And quite honestly, that's where we hope some people go with this. And Valerie says, I think the first time I did this, I was really happy we were opening up this difficult conversation, but having or not having privilege is complex and I have many emotions, and I understand that. Quick question, did you ever think about questions like this in your life before now? And I can see that many people have. So we ask that question because oftentimes when we do this activity, we find that folks of color, BIPOC folks, folks from marginalized populations have thought about these kinds of things because we have to, because we are confronted with them. Often white folks have not thought of these because they haven't been confronted with it. They haven't had to think about it. However, my hope is that certainly in behavioral medicine, that we are encountering more and more conversations of these nature and thinking about these things more. And so again, in the interest of time, thanks for all these amazing responses, really, thank you. In the interest of time, I'm gonna go ahead and keep going and let you know what you will find in the toolkit. So the toolkit gives guidelines for this presentation. And it says that the goal is to examine unearned privilege based on race, gender, sexual orientation, religion, ability, and so on. And so that notion of unearned privilege, privilege that you've received, I think is an important one for people to be able to understand, that it sort of separates them from others. And the objectives of the activity, again, I'll just read them. Recognize that privilege is unearned. Recognize the diversity present within the group. So again, if we're in a room and we get to do this with the stepping up and stepping back, you see the diversity. Explain different types of privilege. Recognize how important it is to not make assumptions, and recognize the value of diversity. And so thank you for sharing and opening up about that. Right.
So here, what we're going to talk a little is about two other activities that they are in the toolkit that we are not going to do it experientially, but we are going to give you some tips on how to run them. Okay. So the first one is the why do inequities continue? And if you can just 30 seconds, put me one word or two in the chat. Why do you think that inequities continue? Kwanzaa says money, system, the benefits of people who could change them. Yes, systems. Some people do not want to give up power. Yeah. People with privilege are comfortable with how things are. Very good point. Yeah. Those with power benefit and make decisions. So I can see that the pattern of what are you seeing here, you know, is like there are several points of view, but there is also a pattern that we are thinking in systems. There is something about the system that needs to change, you know, in order to make this happen. So this is one of the objectives of this activity. Thank you, all of you, for all your answers. I can see that we're growing some emotions here, and this is what we want, to process all these emotions together and to see that actually we can, at least it's my dream, that at least at some point we can be just one big group, you know, with some divisions of power. So thank you for all of your answers. So this is an activity that is not one of the longest in the toolkit. So is one that even that people is going to be exposed to a lot of emotions. It's just 35 minutes, you know. And the idea of this activity is for people also to try to develop some you know, awareness on what's happened with inequities. So the idea of this activity, is to give some scenarios, to give some small text that now I'm going to show an example, and just try to divide the big group that you are going to have in small groups for discussions of these viewpoints. And once they have the discussion, they can come back to the general group. Okay. The questions that we recommend you to try to use are, which views come closest to your own once they are seeing the viewpoints, which views seem most important, is there a viewpoint that's missing, and is there anything that you don't agree with? Okay, they are our recommendations, but of course this is pretty open, and depending on the group that you are talking to, you can or change them or add another ones, but always be aware that most of these activities take time. Okay, so take that very present when you are running these activities. So this is an example of a viewpoint. I am not going to read it, but just take one second on this viewpoint. The viewpoints are, most of them are about politics, about race, about discrimination, about stereotypes, and most of them really make you think a lot. And if you download the toolkit, you're going to find the viewpoints in the page 17 of the toolkit. So, Kathryn, we have a question in the chat, and I know that you did this activity more than me. That is there a group size that you feel works best for this activity?
Yeah, so I would say this and many of the activities we're talking about are good when you can do breakout groups and have smaller groups discuss them. And I would say groups of about 4 or 5 is really good. If necessary, if you end up with a really large group, possibly up to 6 or 7, but really 4 or 5 is really a good number, so that everyone is sort of forced a little bit to speak. So yes, breakout groups, and ideally about 4 or 5, I think.
Yeah, 4 or 5. I was going to say the same. Try to keep the small groups small, so everyone can have a time to speak. Okay. And now Brian is asking, do you have advice for how to address implicit or explicit racist or BIPOC blaming viewpoints?
Yes, so I think that we want to empower everybody on this call, and we want you to go out and empower the people around you to address these kinds of issues. It could be microaggression, subtle, it could be overt. And there's a technique that we teach folks to try and use, which is to really kind of meet that person where they are, and instead of backing off, kind of play dumb a little bit and say, I'm not really sure why you're saying that. You use the term such and such. My experience is that people are sometimes, that term can be pejorative or kind of upset people. Have you ever thought about that? Or I'm not really sure why you're saying that everyone who wears that particular clothing seems to have that characteristic. Can you tell me a little bit more about why you feel that that's the case? So to be able to do it in a way that is not aggressive, but sort of in a way, sort of matter of fact, sort of really challenging them to prove their viewpoint. That's what we suggest, and that is not easy. And so that's why we really believe in workshops like this, where people get to really grapple with these concepts and have experiences, talking them out with colleagues, that prepares them for when that happens in the real world.
Yes, I definitely agree with that. Kathryn and me, we meet 3 times before to speak about the presentation. And really, I'm going to tell you something that happened in these meetings that Kathryn and me had. It's like, we really went over the PowerPoint very fast, but we took more than an hour each of our encounters to process our emotions about the material that we are presenting today. So my recommendation to all of you, and Brian, of course, I am happy to work that with you in All Saints, Brian and me, we work together, is to try to have some time working with the toolkit yourself and the presenters. Because if you don't have some clarity of your own emotions and your reactions to this material, you can lose control of your group. The second advice that I have is that try to pay an eye in what is the majority of the race or the ethnicity in your group. And each time that we are talking about privilege, and we are like Kathryn and me were talking the last time that we meet for this activity, and if you have people of color, you have to start thinking that probably all the answers are going to be, no, I don't have privilege, okay, or I don't know what it is. So for these people to have an experience of privilege is not something that is going to be so accessible. So it is really important to have an idea of what is going on inside, but also what is going on outside with your group. The activity is a little longer, but it's my favorite of the toolkit, okay? I am an ex-psychoanalyst. This is why I believe that each person has so many interesting subjective details. Now I am a family therapist, so I progress, okay? And, after some therapy, I discovered that I don't have to be a psychoanalyst anymore, and as a family therapist, my mental health is much more better. So this activity, I love it because we really focus in the subjectivity of each of the person that is going to be part of this group, and is basically about intersectionality. It's a little longer, okay? And if you go to the page in the toolkit, it's going to be the page 25, is where you are going to find a social identity profile. That is the tool that you are going to use with for this activity with the participants. You are going to distribute this hangout, and you want all of the participants to tell you all the possible groups that they can be in. For example, here we can see in this frame that someone can be a woman, but actually the sex is, you know, a male, and the race is actually Native American, and, you know, the sexual orientation actually is bisexual. So what I'm trying to say is that when we are talking about everything that means the discrimination or subjective experience to be discriminated in one way or the other, there can be a lot of details. It's something that can take some time to discover everything of the subjective details of this participant. So they are the characteristics that some of them are going to be obvious, okay, but some other are not. So we have to be extremely careful to try to be respectful of all of these details that the participants are going to take, and probably this activity is going to, you know, consume more time than the other ones. So now what we are going to do is we are going to do something experiential about the next activity, and this is also one of our favorites, that is to talk about microaggressions, okay? And when we define microaggressions, we have to understand that microaggressions sometimes are not subtle. No, because we have the name micro, this means that they are small, no one see it. No, actually can be seen, and sometimes are very, very explicit and in your face. What is micro is much more the idea that there is not a consequence for the person that is doing the behavior attacking another person. These behaviors can be verbal, non-verbal, and sometimes can be even physical. But the important thing about the microaggressions is to understand that there is some anonymity. There is something that, okay, I do it, but I don't suffer the consequences. Why? Because I am part of the group that has power. Also, we don't have to confuse microaggressions with what is micro-insult or what is a micro-invalidation, okay? A micro-insult most of the time is unintentional, okay? Is not in my awareness system that I know that I am leaving someone out of the group or that I am seeing something that is hurtful, so it's not conscious, okay? But a micro-invalidation basically is dismissing, you know, is not taking the other person in consideration. And this is very linked to the idea of invisibility in the society and how much the disadvantaged groups can suffer of that. So now we are going to share the video, and after share the video, Kathryn is going to tell you how we continue with the dynamic.
So Dr. Pennington, our patient is a 22-year-old male with a history of asthma who presented to the ED today with a gunshot wound to the right thigh. The bullet shattered his right femur, and the trauma team asked us to consult because of his history of asthma. He was stabilized in the ED. He reported some shortness of breath at that time. However, he had an O2 sat of 90% on room air with diffuse wheezes, both inspiratory and expiratory. portable chest x-ray was normal. He was treated with a nebulizer treatment ×2 and had some symptomatic improvement. He was taken to the OR, and post-op, his O2 stat dropped from 95% on 2 liters of nasal cannula to 89%. CTA was ordered, and we were consulted. So he has a history of asthma since he was a young child, and he's been hospitalized 3 times, the last time being at age 11. He's never been intubated, but he reports recreational marijuana use, and the last time he used marijuana was 4 days ago. He's on a controller med that he doesn't usually take regularly, and he actually doesn't really remember the name of that medication.
I'm so tired of violence in this city. It never seems to get any better. You think that people would have something better to do than to kill each other. At his young age, I bet he's already been incarcerated. At any rate, what do you think is going on?
Well, I think that a PE should be high up on the list, but he also has asthma, so that could have something to do with what's going on.
That's good, and that was a better assessment than you did with that patient with pneumothorax who presented a couple days ago in shortness of breath. Assuming her findings are accurate, what's the first thing you think we should do with our gangbanger?
Well, I think we need an ABG and a CTA for starters, Dr. Pennington.
What do we already know about his acid base status?
We haven't gotten an
Did you
ABG.
check his lights?
Well, I was going to say that...
Well, at this point, we have a respiratory alkalosis based on his bicarb, but that doesn't help us in this situation.
That's correct. Let's move forward with your recommendation that we get an arterial blood gas, an urgent CAT scan angiography. What do you say we go see our gangbanger? Is he Hispanic? I know that there's a huge gang problem with Latinos in this part of the city.
Well, he's actually black, but I don't think that
Let's see if your physical exam skills have improved since that patient with pneumothorax.
Okay, so we're going to ask you to keep it there. Probably we are going to have a lot of reactions about this. And now we are going to divide the group into groups of 4. And the idea is for you to think in 2 questions that now we're going to write it in the chat. The first one is what microaggressions you see. And the second one is how these microaggressions affect patient care in this scenario.
And yes, I'll just say one more thing about the video is that there's the attending physician, and the young lady who is presenting is an intern, and the young man who is there is a senior resident. So we're going to do the breakout for about 10 minutes. We want your group to discuss the 2 questions, and when you come back, we'll have someone report back on your experience in that group discussing those questions.
Hello all again, welcome back. So the idea now is where we're gonna go group by group, and one representative of each group is gonna give us a briefing of how the group works. So for room 1, we have Alison, Barb, Bob, and Brian, who wants to tell us how the group went for 1 minute or 2.
Looks like I'm up. Yeah, so our group had a really nice discussion. A lot of richness was picked up in that encounter. I think we all left feeling that same feeling when you look behind like the refrigerator that you haven't pulled out for like a decade and see all the gross stuff underneath there. At least that's how I came out of it feeling. The messages were so consistent and so destructive to everyone involved coming from the attending that it was hard to really untangle them. But we identified areas that, you know, the patient care is obviously not going to go well. The intern is being given a lot of messages about her belonging there and being punished for empathizing and trying to provide good care for her patient. And then the white resident is being given a lot of messages too about what's appropriate behavior for patients and learners. So a lot of stuff.
Room 2, we have Chris, Danielle. Sorry for my Argentinian accent. I don't know if I am saying it correctly, so sorry. Deidre or Dom, who wants to take the word and say something about how was your group? Chris, you are the first name that I have in the list, so Please, can you tell us how the group went?
Wait, are you talking to me?
Yes, Chris.
Oh, wonderful. Well, it was a lovely group, and we wound up going through the microaggressions bit by bit, talking about the ones that were really, partly the ones that were directed by at the patient. And then we spent a lot of time talking about the emotional and cognitive load for the PGY1 that was there, who had these two other doctors that were essentially colluding and wanting her to go along with these racist assumptions about this patient, and just how taxing that would be, both in that interaction, and then also later the processing of those kinds of things.
Sorry, Chris, I was supposed to speak up for our group. I thought we were group 3. But
Don't worry, you're going to have the chance in the next one. Is there something else that you want to say?
I just also feel like that culture is a very malignant culture, because obviously the senior resident is propagating the attending, what the attending is starting, because he didn't even support his intern at all. And that's not the job of a senior resident whatsoever.
Agree.
We discussed how unsafe this environment is as a learner.
Yeah, very, very safe for the senior, but completely unsafe for this woman in this group. So how about, because I see that we have a lot of reactions and still we are processing all of this, how about we just open to whatever any of you want to say for a couple of minutes.
And I think it's also okay if you want to chat your responses too.
Yes.
And I want to say that I am really embracing the silent spaces in this conversation and really appreciating that we gave you a lot to process and to unpack. And if you are processing internally, that's okay. That is absolutely great. And if you would like to share your feelings, that's good too.
I agree. It's too much to process in a short time of 1 hour and a half. So
I see Kwanzaa has her hand raised.
Okay, come on, Kwanzaa.
You guys know I always have something to say, right? No, our one of the things that came up in our group as we were answering the second piece or the second question, in terms of how this would affect the patient's care, thinking directly about the fact that you've got this attending who's going in with all kinds of assumptions. And, I was talking in an earlier session talking about like differentials and things like that. And yeah, you've already narrowed down, you've already decided what you think is going on. And so you're not going to give thorough care. You're not going to give quality care because you've got all these assumptions already pre-formed based on, oh, he's a gangbanger, he's a blah, 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 blah. So that piece, that there's not going to be quality care there. But then also thinking about the resident's position and the fact that he's made this situation so hostile for her. We talk about the effect of stress on our cognitive ability. So when you push too hard and you get to that level where the frontal lobe just kind of shuts down, it's like that affects her ability to do the actual work that she needs to do because she's dealing with all his stuff and isn't able to do the work that she needs to do, and how that can then propagate the exact same issue, like, oh, well, see, you can't even do the exam right, blah, 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 because she's so stressed because of what's happening, and it just ends this horrible vicious cycle, and she can't give the care that she needs because of the state that he has put her in. So yeah, kind of both pieces. She can't even, she's trying to stand up for the patient. She's trying to defend, and do the best for him, but is also in a situation where she may not be able to do the best because of what's around her.
Yes, and I think
Excellent.
the really tough thing about that, Kwanzaa, is that attending has no clue how that stress and that power differential and that humiliation process is twice as hard for this young lady because she's BIPOC. He has no clue about those extra layers of stress, how the microaggressions just, really double down and make all those feelings of humiliation even worse. I feel like we've come a certain way in terms of getting away from what they used to call pimping and that sort of humiliating way of teaching in medicine. And at the same time, we need to be able to talk about that with our majority colleagues on those extra layers of stress for our BIPOC learners. So
I am thinking, Kathryn, that if as a group, and we are not living the situation, and it's taking all of this time for us to process something that we are seeing, I don't want to think how much this woman has to process in this situation. Actually, I think that it's impossible to process all of these emotions and at the same time keep a cognitive high function level. This is why I love, Grace, your comment here. No, we talk about how much the upper level mirrored the attending body language and treatment of the intern. Actually, there was some unconscious communication going on between these two guys, and there was a third part there that was not included in anything. So how much of this cognitive advantage that we have to be accepted or be part of the status quo, no, when we are.
mm-hmm.
Some other comments that we have here is Kathryn spoke about the sense of safety. Valerie is saying we also discussed how we might address this and that the attending behavior may bring up feelings in us, a woman, and behavioral health folks intimidated, and the importance to address that in ourselves and in order to speak up. Completely, I agree with you, Valerie. Here is when intersectionality also play a role, no? Similar messages. I have a hard time considering this microaggression. It feels deliberate. Yes, good point, Alison. Yes, it's like, yeah, sometimes microaggressions don't have anything of micro. They are so exposed. But the interesting thing is that probably there were two guys here that they were not even aware, because it's so common to have, in the same way that we speak about the experience of not having power and what this brings on us, we have to think of the people that always experience power, the lack of awareness, no, in a situation like this. It's normal, yes, all the gangs are Latino or Black. Oh, Black even worse, it's like there is no any type of awareness of that.
Mm-hmm.
So thank you for all the answers. I think that, Kathryn, in benefit of time, we have to move to the next activity. Is fine with you?
Sure, absolutely.
Okay.
Okay, so now I realize I forgot to tell you to have some paper and a pen handy. Hopefully you can grab one. But we want you to actually start processing through and thinking through of some of the activities that Hernan described and the activities that we had a chance to do, and really start to just scratch the surface of brainstorming about your curriculum. So the way we're going to do this, you can see there are 5 questions there. You won't have time to answer all five of them, but I would say pick 1 or 2 as your starting point. So say you've scooped up all this information, you're going to go back home, well, everybody's home, and you're going to start really working on what are the next steps for my program. And we're going to keep us all in large groups. So this is going to be a silent activity for you just for a minute or 2. We'll give you a chance to jot down your responses once you've picked out which 2 you would be your starting point. And then we're going to send you to Breakout again. And I think we'll have time for 10 minutes in the Breakout, maybe a little bit less. If we could do 7 or 8 minutes might be a little bit better, but we'll just pause just for a minute or 2 and let you pick your 2 out and just jot down on a piece of paper what would be your next step. All right, so welcome back, everyone. And we know it's been a long day, and we've thrown a lot at you. And we just want to move into this last part of our presentation by just really asking everyone just to kind of sit back for a minute, just take a few breaths. As we mentioned in the beginning, this is deep work. And just want you to pause and just, you know, whatever you're feeling, it's okay. And so just encourage everybody to, again, just focus on being present here in the room with us, but mostly being present with yourself and giving yourself time to think about this experience and what it means to you. So what we're going to do, we would like to hear back from you, and we are going to once again invite you to respond in the chat and let us know what the experience of this activity was like for you. And we realized that we had a very ambitious agenda with this presentation. And this is a pretty ambitious question that we're asking of you, and we're very aware of that. And we'd like to hear what it was like to go through the experience of thinking some of this through. So again, send it into the chat. And if anyone would like to make a comment, go ahead and raise your hand. We'll try and call on you. Kwanzaa says, it's encouraging to know we're not alone in this work. Yes. Whew, I can exhale. I exhale every time I do these presentations, and it feels like the material is appreciated. Had a collaborative conversation, Deirdre says, to normalize the barriers to implementing the curriculum. Absolutely, and there are many. And we realize we haven't even used two terms I want to focus on. So we put the term BIPOC, B-I-P-O-C, in our presentation. I want to acknowledge that that stands for Black, Indigenous, People of Color, and is a term that unites folks of minoritized background who have been oppressed. And the other term that we haven't mentioned in all of this is systemic racism. And systemic racism is that thing that holds that privilege in place and allows the white senior resident to basically side with the attending. And these are really big mountains to climb. So Samantha says, helpful to take a step back, hear what others are doing, think of next steps. Dom says, great discussion, springboard to move forward, have felt inept and frustrated and wanting to do more. And we find that a lot with people coming together and really humbling ourselves and talking about the struggles and the difficulties. Brian says he was struck by the great opportunities and resources for sharing. Thanks for sharing, great. And Danielle expressing appreciation for bringing the conversation to the forefront of our minds. And I want to say I really appreciate the forum for including this conversation and this language. Pete says, as a person with privilege, discover the rough edges and personal biases whenever he dives into this deep work. Thanks for sharing that, Pete. You know, those are difficult things to talk about, and we really, really appreciate that. Other comments, experiences? Jacqueline says that we, the presenters, set a supportive tone, so it felt safe. That was definitely one of our goals, was to create that safety. And she's motivated to return to her program with renewed energy. Excellent, excellent. Emily says it's helpful that others are asking questions of how to increase anti-racist teaching learning environments. Yes, there are lots of resources out there, and takes a courage to package them together and present them in a certain way. And I think I speak for Hernan when I say, I don't know if maybe you wouldn't say this, Hernan, but consider me on speed dial. Give me a call, email me. I'm happy to step in and provide any support that I can. So,
and if you call me, I can give you the phone number of Kathryn.
Okay, and on that note,
of course, you can call me as well and email me.
Yeah. And on that note, I'm going to turn it over to Hernan to do our wrap up.
So thank you everyone for being here today. The last thing that we want to share just in a couple of minutes are some very basic tips on how to handle this. That is, you are going to see that there are some defense mechanisms when people are exposed to these type of processes in groups. So some of these mechanisms can be dominating the conversation. Okay, some of your participants can try to do that. Some invalidation, okay, say no, it's not like so much like that. You know, this video of the microaggressions is an exaggeration, it's not real. Some other people are going to say, no, I also suffer, but for another problem. And sometimes people of privilege can distance themselves from their group, saying, yes, I have privilege on this, but I actually suffer a lot in another senses. Okay, so the final tips is try to be authentic and genuine, and this is why we recommend to do all of this emotional work with yourself or with the other presenter. I think that this is a very good, you know, to present things of the toolkit is needed at least 2 presenters, because sometimes can be too much to handle just for 1 presenter if you're going to handle this. So if you are the behavioralist in your residence, try to have another faculty working with you or another chief resident or something like that. It's important to address the white privilege and white fragility, but remember that if we put it in your face, people is going to become defensive. So we want processing, and for processing, we're going to use all of our counseling skills. And be brave, you know, it's okay to go through discomfort. We are going to have discomfort, and the people that is going to be participants are going to have discomfort. And address differences intentionally, okay? Differences and accept differences is a big part of all of this, and obviously try to suspend any judgment. This is why the internal work before is so important. So with that, Kathryn, I think that we have a couple of minutes to open to questions or comments or...
I just wanted to say thanks to both of you. It was very helpful, this presentation. It was also, I don't know if you intentionally did this, but to have us break out into the same group of people, that was really helpful. Because hard discussions, it's nice to have, you know, you already met these people once and now you continue the discussion. I found that really helpful.
I will tell you that that specifically was Hernan's suggestion. And it looks like it paid out. So thank you for the feedback.
I just had a sort of a question, maybe advice. We're embarking on a curriculum to address these sorts of issues and help people in the residency become more anti-racist. And as we've been talking about it, we're aware that there are some folks in the program that have engaged in some microaggressions. And so our BIPOC individuals in the program are now really sensitized to working in these group experiences because it doesn't feel safe to address some of these issues. And I guess I'd love to hear your thoughts about how to approach that bravely and with some kind of grace and I don't know, cleverness. It sounds tricky to me.
You want to go first, Kathryn?
I want you to go first, but I'm going to step into the scary space and see what I can contribute. You are absolutely right, Chris. It gets into very tricky territory. And that is why I tend to preface these conversations with just putting it out there and saying, you know what, this is scary. We want to keep it safe. We want to keep it open. And I think that if we could look back in retrospect and change what we did sometimes, that's what we would do. You can't really do that. However, I do suggest every time you start out with this to start out that way. It is very difficult to single out residents, if you're talking about residents, for any kinds of issues, because that gets really tricky. Sometimes you can sort of sneaky go through advisors in a certain way. And I think approaching them in a spirit of just help me understand, you know, some of your responses, it seems to me like you're struggling with this, or it's a hard thing for you to talk about, or you respond with negativity. And, you know, that's not my intention. My intention is not to offend anyone. My intention is for us to all learn together. And that may soften them, take their walls down a little bit, because it's about throwing up walls. That throws up walls and stops the conversation. We know that. So anything you can do to, address that process of the throwing up the walls, it's like, it's sort of like, ew, it's like, oh, it's abhorrent. You hate it, but you have to embrace it as a presenter and see how you can work with it. But it's very challenging.
Yes, I agree with Kathryn. Chris, the two things that I want to add, the first one is that can be a big mistake to don't address it. We cannot let it just happen. It's something that if you don't address it, for sure that these type of behaviors are going to repeat itself. The second, my advice is to try to speak with the people that was involved first individually, doing all the work that Kathryn was saying. Okay, like, I see that this happened. How, where are you with this? I know that probably this was not intentional, or, trying to identify any type of judgment for the situation. But for sure, to don't address it, in my experience, when I see this type of things, generally they escalate. So if you don't address it and you work in a process of individual de-escalation and then move to a process of group de-escalation, there is a big chance that they are going to repeat themselves.
Yeah, my suspicion is that as we're working towards a curriculum and having more discussions, it's going to bring things out in the open that we as faculty have heard about and have not had a chance to confront more directly or call in, I think, to an open discussion about how to be more inclusive. So I really appreciate your thoughts on that issue.
Mm-hmm. And thank you for asking such a great question, Chris. And we are being reminded that we are at time, so we are going to have to end. It's been a really rich discussion. I appreciate you all showing up and being present. And thank you so much, Hernan, for including me in this. It's always an honor to work with you and an honor to work in this space. So
the
thanks,
same,
everyone.
The same. Thank you everyone to being here today. And Kathryn, I am always learning from you. So it's all chance that I have to work with you are going to take it. So
thank you for
everyone.
the great resource too. I think the resource, the toolbox is excellent. Thank you.
It's terrific. It's really terrific. Complete your evaluations, please. Thank you.
Thank you. Bye-bye.
Thank you so much.
See you tomorrow. Bye-bye.